Thank you so much for the warm introduction. Thank you also for the AN Secretariat for inviting us to present the experience of Ethiopia in the development and implementation of COVID-19 surveillance and tracking system. Myself and my colleague Biruhtesfa will give you an overall update on how we have started and our pathway towards implementing a digital solution in response to COVID-19 in Ethiopia. Before I go there, I want to say a few things about the country Ethiopia, which is one of the biggest countries in Africa in terms of both geographical size as well as population. Actually, as the second largest populous country next to Nigeria with more than 110 million population. You may probably heard about Ethiopian health achievements during the MDG era, and we continue to perform better in various health indicators, and one of them is the construction and functionality of health facilities. In the country, we have more than 17,000 health posts where health extension workers, which are the community health workers, are deployed and supporting the community in health promotion and education. We have also more than 3,600 health centers that are providing primary health care service, and more than 314 hospitals. In terms of the current COVID situation in the country, as of yesterday, I think, we have 45,221 confirmed cases, and out of this, 16,311 have been recovered. They were in isolation and treatment centers, and they have completed their follow-up and declared as recovered patients and joined the community. From the total confirmed cases, so far we have 725 cases. 2 cases, mainly foreigners, returned to their countries. And if you look at the data, our recovery rate is right now 36.1%, which it tells actually about the quality of service delivery, and the fatality rate has been 1.6%. Having said that, when we start this activity, particularly the development and implementation of the COVID-19 surveillance and tracking system, it was exactly the day of when the first case was confirmed in Ethiopia, and there was a lot of panic, and we were scrambling to do something about it. And we suddenly wake up with a reality where the country has no viable disease surveillance and tracking system, despite more than 10 years of investment on health information system in the country. What we did was we bring together interested group from different partners as well as the government, and we try to do a quick landscaping analysis on what's available in the global goods space to come up with a quick surveillance platform when we can customize and use it for COVID purpose. And fortunately, there was an ongoing work by our colleagues from Sri Lanka in collaboration with University of Oslo, and we joined that endeavor, and we have started customizing the system based on the country's COVID-19 response protocol. And after a week or 2, we start deploying the tool initially at central level, and then to the laboratories and treatment centers across the city of Addis Ababa. And now the system is being expanded across the country. Our main rationale for choosing DHIS2 at that time was there was actually more mature platforms other than DHIS2, but we believe that given that there are already lots of investment on DHIS2 as a country HMIS platform, as well as the FAME system is built on top of DHIS2. We believe that the investment and all the efforts that we are making to customize and implement DHIS2 as a COVID-19 response platform will help also to disease and case-based surveillance post-COVID. We didn't believe that at that time COVID will stay here this long, and we thought that once the response is over, we can easily tweak these tools to other disease and case-based surveillances. Like there are a lot of issues around TB, particularly MDR TB patient tracking, and for that kind of use cases, the experience of COVID was important, and we believe that we can easily do that based on the experiences that we are going to get from this COVID implementation. So the whole design, development, and implementation for COVID response was actually thinking the post-COVID disease surveillance in mind. And the goals that we have put together during the initial phase of the development of the tool was to identify, isolate, and treat suspected and confirmed cases. The government was preparing isolation and treatment centers, and managing the data and tracking the patients in these centers was one of the biggest challenges at that time. There was also lack of or shortage of epidemiological information to conduct proper risk assessment at national and subnational level. There was a major understanding around where the major risk lies based on the previous data that we had and the amount of information that we have about the COVID pandemic at that time, but it was not really fully supported by evidence, and all the data that we have been collected through the process enabled us to do this kind of risk assessment and map areas where there are highest risk in terms of COVID outbreak. We need also epidemiological information to properly guide the preparedness, and once the case is confirmed in Ethiopia, the response measures in order to break the spread, as well as educate the public in order to protect themselves from this virus. And these were all important pieces that we have put together as goals of the surveillance mechanism that we were putting together. Based on that, we came up with initial core systems, and then as the requirements from the government has been expanding, the tools has been also added. My colleague Biruhtesfa will show us the application suites that we have developed implemented in Ethiopia and then current status, and I will come back to present the other pieces in this slide deck. Thank you. Over to you, Bru.
Thank you, Netsanet. Hello, everyone. So, in order to digitize end-to-end COVID-19 response in the country, we come up with a platform. So, this platform bases on the DHIS2 tracker, which is a case-based surveillance tracker application. And we have built around 6 applications that fetch data to the DHIS2. So these applications play a critical role in capturing rumors from different sources. It can be from ports like airports and also borders. And finally, all the data sets will link to DHIS2 for lab or other surveillance interventions, based on the user roles and also the decisions of the rapid response team. So another example can be also the toll-free application that contributes data or fetch data to the surveillance system. So this toll-free application, for example, serves the call agents in calls for rumor reports, and again, and from lab request to results reporting, and also goes up to admission if the suspects turn out to be positive for COVID-19. And also follow-up and consecutive clinical follow-ups will follow, and at the end, discharge also be in order. Platform have a lot of applications inside and a lot of automations and processes to serve to the COVID-19 response. So there are also other apps like commodity management for dispensing and tracking COVID-19 commodities at centers and stores. So these were built for like previously for other healthcare commodities, but now customized for COVID-19 aspects, and stock management for dispensing. This platform bases and uses a data depot, as you can see in the middle, and that serves as a mediator between the applications. So any rumor cannot just face data to DHIS2, and first it is in the data depot or data pool for further analysis and interventions by the rapid response team and other users in the system. So we use the data depot for as a mediator between these applications. So there are also other applications coming that we are working on for home follow-up. As you know, as the pandemic is registering a high number in the country, so the ministry is planning also to enable home-based isolation. So self-reporting applications are also coming in. Next slide, please. Can I have next slide? Thank you. So having all these applications in the system, you can imagine how the implementation can be challenging in a resource-limited country like Ethiopia, and also during such national healthcare emergency. Though, with all the challenges, we believe we have registered a great milestone in implementing the implementation aspects. So as we can start from the DHIS2, which is the main surveillance tool that we are using, alongside with other applications for rumor capturing. So as you can see, there are around 1,000 users currently using the tracker, starting from the end users. It can be sample collectors, it can be case managers at the isolation center or treatment center, and also decision makers at all levels, starting from EOC, regions, and also the Ministry of Health. And as you know, DHIS2 also supports the Android version for tracking patients for the tracker. So there are also greater than 120 mobile version users, especially these users are the sample collectors that are, as you know, sample collectors are mobile and moving place to place to collect sample from suspects. So the sample collectors use the mobile version, and they enter data in the sample collection data in request forms to the tracker using the mobile. And they are also benefiting the offline access to the tracker. So speaking to the data aspects, currently we have in the system around 200K laboratory tested cases in the system. So even if the system automates the in-between COVID-19 response automation or protocol, starting from rumor investigation to discharging, currently we are highly focusing on the laboratory aspect because it is the major and cross-cutting system, or I can say protocol of the COVID-19 in responding to the pandemic. So currently there are more than 200 cases, an increasing number actually, since we have a live system. So laboratories also nationally using the COVID-19 for tracking of order, receiving, results reporting to the community. And the other great functionality we have is text messaging. for alerting negative COVID results to the community. So I can say Ethiopia currently is testing around 10K up to 17 or up to 18K per day. And the positivity rate is around 9%. And the remaining is negative. So you can imagine how the surveillance team will have a hard time in communicating the negative results to all the clients. And it's also time taking, as you can imagine. So the system have a functionality of alerting negative COVID-19 results to the community. So also solved a lot of problems for the surveillance team by communicating negative results. So also interoperability application for automatic order and result reporting. I can show you in the next slide about that. And alongside with the laboratory automation, the treatment centers and isolate centers through the case management section are also using for daily and weekly reporting aspects. Next slide, please. Thank you. So as you see, as you complicated area or section, and there are devices involved for order receiving, order receiving and results reporting. So we have to come up with another interoperability layer to interact and interoperable these two systems by using OpenHIM mediator. So functions. Sorry, I've lost the slide. Sorry. Thank you. Can we move to the slide 6? I think it's slide 6, interoperability. Thank you. Okay, I apologize for that, for the inconvenience. So here, as I was saying, the interoperability layer serves to interoperable these two systems, DHIS2 and the politic. So the automation works DHIS2 and also communicates results to DHIS2. And DHIS2 will be responsible for Hello? Sorry, our connection was interrupted. So as I was saying, thank you. As I was saying, DHIS2 will be responsible to send out the orders to LIS through the opening mediator, and LIS will be responsible in receiving the orders. And once the results are ready, and the lab technicians also use LIS or Polytech system to send out the results to the DHIS2 through the mapping mediator. So the results will be available for the decision makers, surveillance team, and anyone from the pandemic responding team can access DHIS2 based on their user management. Next slide, please. So moving to the other 6 applications, or the rural culture application implementation status. The call center app is, as I was saying, allows call agents to manage calls from the community. It can be for health information, rumor reporting from their area, and also abusers also calls and busy the line actually. And it actually helped the ministry to navigate through the data and intervene how many of the calls are important and actually serving the community. And as you can see, a lot of people, around 800K people have called for health information. And there are only around 5,000, almost near to 5,000 rumors have been reported through the call center, through the call center app or toll-free app. So the port of entry applications also serves the health workers at the airports and also at the borders, and allowing registration from commercial flights and also returnees from different countries. And if these returnees or travelers from airports and borders have to perform a laboratory test, they have to, their recording have to send to the DHIS2 tracker for further investigation and laboratory the data management. And also at the end, results communication will be through the DHIS2. So the community management also is implemented at 2 national stores for COVID-19, and major isolation treatment centers are also using the community management system for dispensing and community management for COVID-19. And the health facility application, this application actually is being used for reports from the health facilities that are coming with symptoms of COVID-19. And the health workers don't have any standard reporting tool to report to the higher authority for such individuals. So they use this application to report to the higher facility or the hospitals and so on. So thank you. This is from my side, I think. Netsanet, over to you.
Thank you, Bro. As you can see from the previous presentation, a lot has been happening in terms of customizing, developing, and deploying various digital health tools. However, as you can imagine, all these investments on digital tools development and implementation can be well justified only if the data generated by these systems can be used at the point of care as well as at various levels in the health system for COVID-19 response design, as well as doing other community interventions in response to the impact of mitigating the impact of COVID-19. And we have been supporting the government of Ethiopia to develop various information products like dashboards and also different communication materials based on the data that has been generated through this system, and also triangulating it with other important routine data sources that has been in place across the country. For instance, as you can see from this slide, we have been developing a daily COVID-19 monitoring dashboard where the public can see the number of confirmed cases, laboratory tests that has been conducted, how many people died because of the COVID-19 infection, and also the regional distribution in the number of confirmed cases. This has been happening daily since the first day COVID-19 case has been confirmed. In addition, Brooke earlier mentioned about community level surveillance, where health workers, particularly the health extension workers, are going house to house and screening individuals and also conducting health communication and promotion in relation to COVID-19. And they are collecting a lot of data to understand the community distribution and the risk mapping in terms of where the government should target in terms of its communication work, as well as when there are issues, identifying how many people will be affected in certain geographic areas. I will show some dashboard later around this. In addition, in each of the tools that Brooke showed us earlier, there are dashboards to routinely measure key performance indicators for different case teams. For example, how many suspects were identified through the call center and passed to the RRT, that's the rapid response team, and how many of the suspected cases have been investigated, and also how many lab samples were collected and what was the turnaround time, the contact tracing practice and process, and the case managers also have dashboard to find out how each hospital serving as a treatment center is performing in terms of day-to-day patient follow-up, as well as outcome of the treatment within the treatment center. Same is true with hotels and universities that are currently serving as isolation centers for suspects and those identified through the contact tracing. These are some of the dashboards that we have taken from DHIS2. As you can see, the first one is the first pie chart shows reasons for laboratory testing, which is being updated daily, and most of the testing in Ethiopia is being conducted through community surveillance. Others is followed by contact tracing and suspects identified through different processes like the screening at the port of entry, as well as other situations. And the second one is the trend in terms of how suspects are identified, whether it's through the toll-free line, the port of entry, community surveillance, health facility, or contact tracing. We have additional dashboards that we have developed for the government of Ethiopia to daily monitor. As you can see from the screen, the one on the left is daily cases in terms of laboratory tests, confirmed cases, recoveries, and deaths, and also people in number of cases in treatment center. And out of that, those in critical conditions like in ICU. And the dashboard on the right side is cumulative cases, the laboratory tests that we have conducted so far from April to yesterday. And you can see that the trend in the chart, and also total confirmed cases, total recoveries, deaths, and the recovery and fatality rate. We have also disaggregated this data by regions to show that how each region is affected by this pandemic. And as you can see, the city of Addis Ababa is the one heavily affected by the pandemic, and also most of the testing is happening in Addis Ababa. We have also tried to show the trend in terms of total confirmed cases, recoveries, and deaths. And we have been comparing these three on a daily basis to show how the curve looks like for the country. And it's going up, as you can see it from the graph. In terms of risk analysis, based on the DHIS data that was conducted in 2018 and the mini DHIS in 2018, there was also an attempt to map the risk for the city of Addis Ababa based on exposure, comorbidities, access to health facilities, access to communication, other socio-economic conditions, as well as total COVID-19 risk mapping, which is an aggregate of these five different factors, risk factors. And as you can see, as it is an urban area, there are lots of people with comorbidities, and that's why you see a dark green in here. And exposure risk and total risk is average, whereas since it's a capital city, health facility access, as well as access to communication and the socio-economic condition of the people is relatively fine. The third important piece in our work is governance of all these digital health tools, as well as the data access and use. This was an afterthought initially, but we learned that it's an important piece that we need to take it side by side. As part of this process, as the data in the system grows, there were a lot of requests for access to the data, as well as sharing the data through different platforms. So we have to help the government to come up with a protocol to manage the overall data access and sharing policy of the country, which includes managing user accounts, managing data storage, including hosting, and also backup and sharing of the COVID-19 data, which is a little bit critical as it contains individual data, patient level data, that needs to be de-identified when shared for analysis and further research. In terms of structure, which was another important component, initially it was started under the leadership of development partners, but once we got used to the pandemic, we have to make sure that the government owns and leads the whole process, and a national implementation team has been established under the leadership of the government, which includes all the government critical stakeholders, as well as implementing partners supporting this process. And the national implementation team has 5 sub-teams within it: the development team, the rollout team, the requirements gathering team, the data analysis and use team, and server infrastructure management and logistics team. And all these teams have been working together under one project set up led by the government of Ethiopia. And when the system is maturing, and when based on the learnings that we have in terms of its implementation in Addis Ababa, we have also helped to establish regional implementation teams, mainly focusing on the rollout of the system, as well as support and gathering of feedback from the actual end users. One of the challenges that we had, especially at the initial stage of the system rollout, was our inability to provide the training in the traditional way. Given the COVID-19 situation, it was not possible to gather people and provide the training. We started a Zoom-based training, but that was not enough, mainly because of the challenge around bringing everyone on the same page within a short period of time. So we have to come up with another innovative strategy for people to use training content and conduct a self-paced learning. And for that, an e-learning platform was customized and used for delivery of electronic COVID-19 surveillance content. This was a step-by-step training video that helps end users of the application to use the platform effectively. It's hosted under the training platform of the International Institute of Primary Health Care, which is another government entity at the Ethiopian Public Health Institute. And they have the mandate to provide training and certify them. So we use that as an opportunity to deliver this content electronically. The training instance of the COVID surveillance and tracking system was also made available for trainees so that they can practice on how they can use the system rather than going and using the production instance for training purposes. Finally, I will say a few things about what we have learned from this process that can be used for post-COVID disease and case-based surveillance. One is when we developed this system, we have been documenting all the learnings as well as the knowledge in order to use it for other case-based surveillance. For example, there was a struggle around maintaining the quality of the data and tracking patient MDR TV patients. It's a big problem in the country, and for that kind of use cases, our experience and our knowledge in COVID-19 will be utilized in order to quickly deploy a similar platform that can serve TB hospitals in the country. Another one is we have been focusing too much on aggregate reporting, and we have learned a lot in terms of the need for patient tracking, and this is a big paradigm shift in our country, and especially the way we designed the country's public health emergency management system has been mainly an aggregate for facilities to send reports rather than helping them to develop and implement a tracking system to follow up their own patients in case of emergencies. And I think post-COVID, this is one of the areas that the country will focus in terms of emergency management. The third one is the training system that we have said earlier. There is a strong need from the government to continue our gains and also our systems to run smoothly during this pandemic, particularly for the essential health services. This requires following up our reporting systems and also supporting health facilities on the deployment of DHIS2 on their data quality verification mechanisms, efforts around data use. And this was something that was paused for some time, but this new approach of doing it remotely and electronically helped us to continue all others, to support all other systems that were in place before the COVID outbreak here. And then quick deployment and development and deployment of tools is possible. This was something new. We were usually taking long period of time, requirement gathering, design workshops, development, testing, user acceptance testing, and then piloting, and then deployment after 2-3 years. And I think the COVID situation has gave us this experience of landscaping the global goods, what's out there at open source platforms that we can customize and use it in countries like us where we can't afford that kind of time and investment to develop everything from the scratch within the country resources. Finally, all the work, all the response that we are having here in Ethiopia right now around COVID is data-driven, and we have been promoting, advocating for data use for a long period of time, but the COVID situation brought forward that work, and everybody believes that now using data for evidence-based decision-making is not an option. And post-COVID response, as well as continuation of essential health services, increased the data demand, and we hope that we can continue to keep that momentum and continue on that gain on other services, even after the COVID outbreak. Thank you so much. These are some of the presentations that we have prepared today, and we are happy to answer some of the questions that you have. Thank you.
Yes, thank you, Sir Netsanet and Sir Biru, for coming up with this presentation and sharing them to the AHIN community. So to our participants who haven't entered their questions yet, please feel free to enter them now. Our first question reads, how soon after the first case were you able to put your DHIS2 in production, and what were your challenges in setting it up?
Let me start, and Brooke will continue. It took us like 2 weeks for the initial production deployment. As you know, may probably know, Ethiopia has a different calendar. So we decided that changing the tracker into the Ethiopian calendar will require months. So we convinced the health system leaders that this is an emergency response and we don't have that luxury to sit and customize the DHIS2 core to change the calendar to Ethiopian. So they were convinced, and we are still using the Gregorian calendar for that deployment. This was one of the challenges that we had. But the main challenge was everybody was not in an emergency mode, like every system deployment and development. The users were sitting there and asking for more features, more additional requirements, and even there was no clarity on some of the protocols at that time. And we were also struggling when they changed the protocol. We have to sit and customize everything. And another challenge was in the treatment centers. We didn't have any AMR or tracking system. And given the problem with the transmission of the virus in using the paper-based tools, we had to also customize the DHIS2 tracker released by University of Oslo for treatment centers to help them register daily follow-up of their patients. These were some of the challenges that we had, and also the port of entry application was not ready at that time, and we had to do our own from the scratch on top of DHI, using another tool, and also enabling data exchange between this new legacy application that we have developed locally and the DHIS2 was not an easy exercise. So we believe we took the deployment into production mode as early as possible in terms of both technical and administrative feasibility, but there were still a lot of challenges when we start the implementation. As Baruch said earlier, the lab system was not in a position to support this, and the data exchange, particularly some of the tools that we have deployed, were not standard based, and we had to do a lot of mapping and customization of OpenHIM for this purpose. All these challenges were there, but we have been working hard to overcome them, and now we believe that we have a functional system after 6 months of adding, tweaking, and customizing the tool. Over to you. Thank you.
Sir, our next question is, how many IT staff did you dedicate to support your DHIS2 for COVID-19?
At the central level, we have 5 or 6 developers in charge of customization, but that was not the big problem. Most of the human resource need was around training, implementation, support on the ground, as well as supporting data entry at labs and also isolation and treatment centers. We had to bring lots of temporary staff that will serve as data encoders, mainly because we had also lots of backlog data that we need to enter into the system, and also data that were not initially captured and that needs to be further customized and added into the tool. In terms of implementation support, it's a big country. For Addis Ababa itself, we have been using more than 30-40 new fresh computer science and information technology graduates that were quickly trained and deployed as interns before actually the COVID-19 came, and they were really useful in terms of going place to place, training healthcare workers, supporting their day-to-day technical questions, as well as dispatching and managing the whole device on the ground. At the center, the human resource need was not that big, but for implementation and support on the ground in Addis Ababa, as well as in the regions, it was a lot. Thank you, over to you.
Thank you, sir. Our next question is, one of our challenges with data management is identifying patients. So do Ethiopians have a national ID?
So
We don't have, go ahead, bro.
okay, thank you. We don't have a national ID as a country, but for COVID purpose, we are trying to use an auto-generated ID that's coming from DHIS2. So we're trying to promote and show the ministry how the national standard IDs can be critically important for patient management and for also tracking, especially for such emergency and contact tracing needs of aspects of the COVID-19 response.
Our next question is from Dr. Carl from CDC. The question is, what LIS is being used?
So the LIS that we are using is called the Polytech, and it is being implemented in most of the national labs and regional laboratories. Thank you.
All right, thank you, Sir Biru. Our next question is from Dr. Nirmal. He's asking, did you use open source for interoperability layer, or was it custom built?
So we have to build on a custom based, but the protocols are based on HL7 version 2 of the ALICE protocol, and from the DHIS side, it's based on the so it's completely the custom based. Thank you.
Thank you, Sir Biru. The next question is from Sir Sean Broomhead. What standards did you use to support the interoperability layer, NEFIRE or IHE profiles?
Yeah, it's actually related to the previous answer of mine. So we have used, as you know, the LIS is based on the HL7 version 2 communication protocol, and that is what we have used to send orders from DHIS2 to the Polytech, and we have used the JSON format to send out orders, and the LIS also through the newsletter sends JSON format results to the DHIS2. So that is the protocol we have used. Thank you.
We have another question from Dr. Carl. So is DHIS2 used for contact tracing?
Yes, contact tracing feature is in order in DHIS2. So what we are doing is during the registration, this is research we that individual with a contact.
Sorry. I think the signal is getting poorer. So maybe can you try answering it again? Sorry.
Okay, no problem. So the DHIS to have a contact tracing feature by linking an index case to the contact, creating a relationship with the records. So yes, it has a feature of contact tracing and it's being used. Thank you.
Hello. Our next question is also from Dr. Carl. So just to confirm, all health facilities are using smartphones or tablets to enter cases?
So some of the facilities are using tablets, and some of them are using desktop computers based on their convenience. So it's a mix of. Thank you.
Our next question is from Dr. Alvin. So did you encounter resistance from some stakeholders, and how did you manage this?
Yes, there was resistance starting from the national level. There were some legacy tools like Excel-based forms, ODK-based data collection tools that they have been using at the start, and they were comfortable with that. But when we brought this forward, there was initial resistance to get them stopped those legacy tools and switch to DHIS2. This was also the same with the lab team. It took us a long period, asking us to add lots of different features in order to get them use the system. But through constant engagement and also listening to their needs, tweaking the tool to accommodate them, and putting even data encoder next to them to help them in data entry helped us in order to overcome that resistance. But still there are resistance, particularly from some of the treatment centers, particularly the healthcare workers treating COVID patients are not regularly updating and entering data into the system, and it's difficult to have data encoders and data people at that center to help them in terms of the data management. And there are lots of challenges around that, and we are doing a lot of training and a lot of support on the ground as well as remotely in order to help them start using the tool. As you know, one of the challenges with the tracker is there are lots of users in the system in order to get full picture about a single patient, starting from the RRT, the rapid response team starting initiating the registration of the suspect into the lab, people taking samples and also communicating results, and then the contact tracers going and registering contacts of confirmed case, as well as the case managers treating a confirmed case in the treatment centers. Everybody has to enter the data in order to get the full picture about that particular suspect and then confirmed case. This is a bit challenging. Unless everyone is on board, this tracker cannot work, and this was the major challenge that we have. And some of the resistance around the lab has created a lot of delay in the implementation of the tool originally. Thank you.
Thank you, Sir Netsanet. We're almost reaching the time, so maybe we can entertain one more question. This question is from Sir Sean Broomhead. In South Africa, we had a big uptake of COVID case management integrated with the rest of our DHIS2 COVID surveillance package. This needed a lot of work on SOPs, so did you have a big need for helping users develop new SOPs?
Yes, I think this is an area that we need to continue working on. Having the tool by itself will not take us to the end. We have to develop the SOPs based on the national COVID-19 protocols. The protocols are broader, but we need specific SOPs for the different tools that we have. And part of the training should be integrating using of the tools based on the national SOPs for different users of the system. I completely agree. This is an area that we need to work on and support the government to develop and implement it.
Thank you, Sir Netsanet and Sir Biru. So before we wrap up the session, I would like to call on our AHIN's Executive Director, Dr. Alvin Marcelo.
Thank you, Charisse. Thank you, Netsanet and Biru. We're very impressed with the work that you've done. We actually also are in our own journey with our COVID-19 system, and we are one with you in realizing all of the challenges that one would face when you want to scale something at national level. I think your decision to use the DHIS2 was very timely, and the 2 week ramp up actually was very fast. Um, we hope that we can connect you to our own implementers here in the Philippines. Not all of them were able to join us tonight, but I have been sharing with them your slides and with your permission, of course, your recording. For the people in the call, if you would like to have more of similar topics from other countries, what they have used for national data collection systems for COVID-19, just let us know either to the mailing list or just email Charisse. We will have a three session webinars in the next 3 weeks. Sorry, next 6 weeks between Africa and Asia, and I hope that you can join us then again. Thank you very much and good night, everyone. Congratulations, Ethiopia, and stay safe.